Welcome to AllAboutRx. Today, we're diving straight into the respiratory system. I'm so excited you're joining me for this explainer because we're going to trace the fascinating, life-sustaining journey of a single breath of air. I mean, we breathe roughly 20,000 times a day without even thinking about it, right? But the underlying machinery is it's nothing short of an anatomical marvel. Let's get into it. Here is what we're covering today. First, a welcome to the respiratory system. Then we'll navigate the conducting zone, check out gas exchange in the respiratory zone, explore lungs and breathing mechanics, measure lung volumes and gas transport, and wrap it all up with some essential clinical correlations. All right, Section 1, welcome to the respiratory system. Let's quickly establish exactly what this system is actually built to do. It's so easy to just say breathing, but this system is the ultimate multitasker. Sure, taking in oxygen and expelling carbon dioxide is the star of the show, but it's also constantly working to keep you in balance. Did you know it supports your acid-base regulation? Yeah, exhaling CO2 actually adjusts your blood pH. It also allows for vocalization as air flows over your vocal folds, and it offers critical airway protection by using a mucociliary escalator to constantly sweep out pathogens. Pretty amazing, right? Functionally, the whole setup is cleanly divided into two areas. First up is the conducting zone. You can kind of think of this as the body's built-in HVAC system. Its only job is to warm, humidify, and filter the incoming air. There is absolutely no gas exchange happening here. Then, right down at the very bottom, you have the respiratory zone, which is the highly specialized site where the actual swap of oxygen and carbon dioxide occurs. Moving on to Section 2, navigating the conducting zone. Let's physically follow that breath of air. The journey kicks off in the upper respiratory tract, which is all about conditioning that air. Air travels step by step through the nose and nasal cavity, past the paranasal sinuses, and down the pharynx. Then we hit the lower respiratory tract, starting at the larynx, or your voice box. From there, the air plunges into the trachea. This is a rigid tube kept wide open by C-shaped cartilage rings. At the bottom, the trachea bifurcates or splits at a junction called the carina right into your right and left primary bronchi. From here, it's like a branching tree. The bronchial tree splits progressively into secondary and tertiary bronchi, and finally into these tiny bronchioles. Now, these bronchioles completely lack cartilage, but they contain smooth muscle, meaning they can actively constrict or dilate your airways. Now, what's really fascinating about that primary split is the asymmetry. The right primary bronchus is actually wider, shorter, and much more vertical than the left one. So why does that matter to us? Well, if you or a patient accidentally inhale a piece of food or a foreign object, it is significantly more likely to travel down that path of least resistance and get lodged right there in the right lung. It's a perfect example of anatomy dictating clinical outcomes. Section 3, gas exchange. The respiratory zone. Let's keep moving. Moving deeper, right past those terminal bronchioles, our breath finally arrives at the respiratory zone. This is where form truly meets function. Zooming in microscopically past the respiratory bronchioles and into the alveolar ducts and sacs, we find these clusters containing millions of tiny balloon-like structures called alveoli. This is exactly where oxygen and carbon dioxide rapidly diffuse between the air-filled alveolus and the blood flowing through the surrounding pulmonary capillaries. For this diffusion to happen in an instant, the barrier has to be paper thin. This incredibly thin alveolar-capillary membrane relies on flat type 1 pneumocytes to pull off the actual gas swap. But there's a catch. The moisture inside these tiny alveolar spheres creates surface tension, basically making them want to collapse inward. Enter the type 2 pneumocytes. They secrete a crucial substance known as pulmonary surfactant. This drastically reduces that surface tension, keeping the alveoli fully inflated and ready for your very next breath. Section 4. Lungs and breathing mechanics. Let's pull back to the macro level. Just like the bronchi, the lungs themselves are wonderfully asymmetrical. The right lung is divided into 3 distinct lobes, but it sits slightly shorter because the liver is taking up real estate right beneath it. The left lung, on the other hand, only has 2 lobes. It basically sacrifices that third lobe to create the cardiac notch, which is a physical space to accommodate your heart. Surrounding all of this is a protective 2-layered sac. You have the visceral pleura sticking right to the lung surface and the parietal pleura lining the chest wall. The fluid-filled, lubricated space between them provides the surface tension that keeps your lungs pulled open tight against your ribcage. So what's the crucial mechanism driving our breath? It's simple physics, specifically Boyle's law. Breathing mechanics are driven entirely by pressure gradients. Boyle's law tells us that as volume goes up, pressure goes down, and vice versa. So as our muscles change the volume of our chest cavity, the intrapulmonary pressure inside changes inversely. That's what either pulls air in from the atmosphere or pushes it right back out. Let's look at how this plays out physically. Inspiration is an active process. Your diaphragm contracts and moves downward while your external intercostal muscles elevate your ribs. This expands the chest cavity, drops the pressure, and air simply rushes in. Quiet expiration, conversely, is remarkably passive. You literally just stop flexing. The diaphragm relaxes, and your body relies entirely on the natural, rubber band-like elastic recoil of your lung tissue to gently push that air back out. But who's operating this pump? While this whole mechanical process is flawlessly controlled by both neural and chemical signals from the brainstem, the medullary rhythmicity center acts as the metronome, setting your basic baseline rhythm. But it's actually your central chemoreceptors that are the main drivers of ventilation minute to minute. They're constantly tasting your blood and spinal fluid. They respond most sensitively to increases in carbon dioxide and the resulting drop in pH, immediately signaling your body to breathe faster so you can blow that excess CO2 right off. All right, Section 5, Lung Volumes and Gas Transport. Let's talk numbers. Using a handy tool called spirometry, clinicians can measure specific air volumes to map out your overall respiratory capacity. You've got your tidal volume, which is just the air moving in and out during a normal, quiet breath. Then you have larger metrics, like vital capacity. That measures the absolute maximum amount of air you can exhale after taking the deepest breath possible. Mapping these volumes is totally crucial for diagnosing everything from asthma to fibrosis. However, there is one massive exception to standard spirometry, and that's the residual volume. This is the air permanently trapped in your respiratory zone that keeps your lungs from collapsing completely. Because you can literally never exhale it, it simply cannot be measured by a standard spirometer. To figure out that specific number, we actually have to use more complex tests like gas dilution. Let's talk transport. Once oxygen successfully navigates the airways and diffuses across that thin alveolar membrane into the blood, it needs a ride. An impressive 98% of oxygen binds tightly to hemoglobin inside your red blood cells for secure transport all the way to your hungry, active tissues. On the return trip, carbon dioxide is handled a bit differently. About 70% of carbon dioxide doesn't just float freely in the plasma, and it doesn't all ride on hemoglobin either. Instead, it's chemically converted into a water-soluble molecule called bicarbonate. This brilliant workaround allows massive amounts of CO2 to travel safely back to the lungs, where it's converted right back into gas and exhaled. Finally, Section 6, Essential Clinical Correlations. Let's tie it all together. When this machinery breaks down, the disruptions are severe. For example, if air enters that pleural space between the chest wall and the lung, it breaks that negative pressure seal we just talked about. This causes a pneumothorax, or a collapsed lung. Or think about premature infants struggling with neonatal respiratory distress syndrome. Their type 2 pneumocytes just haven't matured enough to produce surfactant, which leads to massive alveolar collapse. We can also categorize diseases mechanically. Obstructive diseases like asthma and COPD restrict airflow going out, whereas restrictive diseases like pulmonary fibrosis stiffen the lung tissue itself, so it just can't expand. I will leave you with this final provocative thought. We know that for perfect gas exchange, the airflow or ventilation must perfectly match the blood flow or perfusion. But if either of those is disrupted, say a pulmonary embolism blocking blood flow or pneumonia filling the alveoli and blocking airflow, it creates what we call a V/Q mismatch. So how does the rest of the body compensate for the resulting sudden drop in oxygen? It's a fascinating puzzle that drives so much of respiratory medicine. Thank you so much for watching.